Our next speaker is Dr. Mark Simpson. Mark is the Chief Clinical Information Officer and Executive Director of Clinical Engagement and Patient Safety at eHealth New South Wales. He leads a team who ensure that clinical solutions are useful, usable and fit for purpose, which reflects very well on the discussion we've just had. The team facilitates clinician engagement in all aspects of solution design, decision making, where there is a potential impact on patient care. Over to you, Mark.
Many thanks, George. Many thanks, audience. What a fantastic presentations we've already had. Not always great to follow the Secretary and Joanna, but here we go. Look, we've got an opportunity here to reconnect. Unfortunately, the meeting that John has just referenced, some two and a half years ago, I didn't realise at that point it would be 2.5 years before we had the chance to physically meet under similar circumstances. What an impact it's had. I only arrived in January 2019, so I chose the most exciting 3 years to come over, didn't I just? Look, we've got, I think, about 15 minutes, George, just to try and go through an organisation, eHealth New South Wales, of 2,500 staff in 15 minutes. And all of the work they do around safety. So I'm going to try and cherry pick some of the opportunities that are very relevant, hopefully, to today, but also open an invite to anyone who would like to know more. I'm sure through the conference and also through direct connections, I would be happy to follow up if I don't touch in detail during the course of this session. To really pick up on the theme of the safety, especially for not only medications, but the even some of those last questions around that, how do we implement, how do we deliver and develop, but also touching on those areas such as education, training, and maybe I'll pick up one of those questions at the end of this, just so I can maybe reflect on some of the thoughts that we've had with some of our international colleagues as well. Look, the 5 points on the screen right now are very much, this is my structure, 3 years that I've been here. We now have those divisions with staff covering safety and quality. Many of you will know Peter Kennedy, who has been around, I think, the whole of the system in his time. Clinical engagement, really what we're talking about here is how do we engage with all our practitioners? Secretary just referenced 170,000, so I think that also alludes to one of the questions. Any state system of rollout implementation is always in New South Wales going to be of significant size. Design, we've touched on a number of that issues around design and design opportunities, but also knowing that this digital world and this ever-increasing digital care footprint creates, as Joanna's referenced, unfortunately some new opportunities to do some different ways and workarounds that may not be governed or safely environed for the care that they are delivering. Prototyping, I'll touch on this in one of the slides, and of no anticipation, but it actually only exists a few hundred metres away from this location just by happenstance. Apologies. And then the last one on the screen is research, and again, what an audience. What an audience. I've had the pleasure to take on enterprise research from eHealth as of the 1st of July, so I'm looking to the audience for all the support and engagement that I can get. Not surprisingly, safety in the environs of digital delivered care cover many of these aspects, so I'm trying to ensure that we touch on the relevant areas that you would like to know more and give us some time for questions at the end. Strong ethos of governance, very heavy on those experts who are actually participant in delivering care. Data quality, data analytics, data insights and data intel is probably one of the biggest current events and next events to understand the system. Human system interactions, covering human-centered design, the actual care, and the Secretary gave us one example of where human systems and the interaction can create novel challenges. Safety assurance, especially for those systems that are now embedded, and some of the problems that we'll touch on are that many of the systems were designed and delivered not to connect to each other. Yet now we work in an environment that is truly connected. Implementation, I think we just touched on that several times there, but that actually the engineering of implementation of large and small digital product, services and platforms in and of itself is an art form and a science. And that, again, Joanna just touched on that at the last point. Technology itself brings its own risks, but also can create its own positive opportunities. I think that was a very nice slide on the positive from Jeffrey. Always the worry that you're going to hit it twice now. So these four areas are very much part of the team for clinical safety, and I see a few of the members in the audience from my team. Integrated safety governance, very much, as I said, at the heart of everything we do. Safety hazard and risk tools to understand and manage, especially for the size and scale of some of the digital product, services and platforms we run in New South Wales. Traceability, not only the system itself to know who's done what, but also traceability when we're designing and enhancing systems. And we touched on there, especially from Joanna's point, the potential for testing and ongoing evaluation. None of the systems that we've rolled out stand still. They continue to be developed over the time that they're being implemented. Let you read about HCD while I take a glass of water. Design approach, particularly around human-centered design. Many of you would have already been hopefully engaged in either human-centered design or design teams. For those who want to know more, Tom Loveday, my Director of All Things Design, is very much leading, from my perspective, on all things within the digital service products and platforms that we're deploying as eHealth New South Wales, where human-centered design, the user experience, the user interface into the digital systems are very, very important. And I think, again, one of the questions earlier on, why did we get a spike in those first 70 days? I think many of you have already experienced that taking on a new system, whether either professionally within health or anywhere, takes a period of learning. And also there are those challenges of where if staff feel that it's not working for them, they'll create workarounds. We have some of the most intelligent, inventive, guileful staff who will work things out themselves. And part of that challenge is to ensure through design teams, but also that ongoing engagement, that we can work with our care staff to understand where it's not working. And more importantly as well, where it's working to build more, because that's another facet, and again, I think that echoes from Jeffrey's comments earlier on, that 90% positive is often lesser focused on because we're so concerned about the 10%. Many hundreds, if not thousands, of staff across the state, when we engage with you all in a design governance, this predates my arrival. Smart folk got together and worked out, if you're going to engage through a design working group, these are the 6 domains of design that you are most likely going to be involved in, one of those 6. If ever you think that you would like to be involved in a design working group, those are the 6 domains that particularly we will require staff to be involved. Nearly all of the design working groups have a heavy clinical focus and a heavy clinical engagement. But you can see in there those domains, and this gives us our design assurance that we cover all of those 6 every time we do a design working group or a clinical solutions deployment. I think there was a question, a comment earlier on about building the thing right. It's not perfect English, but that's the challenge where rather than trying to come at this as a retroactive corrective action, we actually have a lot of experience now with design ethos, design principles, eye tracking, location, coloration, drop downs, radio buttons. All of those have in and of themselves design features that can either enhance safety or may clutter and or confuse. All staff who would like to be part of the design working group, we always look for them to have true delegated authority. Part of our challenge, and we've seen this slide from Joanna, the time scale to deploy state digital care product, service and platforms in New South Wales is often significant. And often the world has changed from when we started to when it gets to near finishing, and then when it becomes more of as a continuous improvement, it's even more that other digital offerings or models of care have come along that were not even in place at the start of the rollout. I don't think it's a surprise that it needs a strong business case and leader, but again, the biggest challenge when designing and developing is to understand the business question you're trying to answer. We have a challenge as humans for scope creep and it morphing. And it was set out to answer a particular question, yet halfway through the project program, it starts to change and it can actually start to answer a different question. And those are some of our inherent problems for, especially when projects or programs take a significant amount of time. Little plug, it's only just had a soft launch, so it might be good that the Secretary's not here. She's blessed it and supported us, but it's only its first flush of youth. Prototyping Centre on the Macquarie Park site is one of those areas that have overnight success that's taken me nearly 2.5 years after visiting the Kaiser team over in the US, is very much trying to get those linkages between off-the-shelf vendor products, the system of making things work. It's not a pure, this is software, or this is a shiny device. It's multifaceted, that it often requires the building. It often requires the diagnostics. It often requires the services and ancillary capabilities to ensure that it all works to a holistic state, rather than this just being in any way, shape or form dropping in a piece of tech. And that's probably, if anyone wants a single take-home message, that's what I'm here for, to try and assure that we don't end up delivering a single item, device or tech, rather than actually understanding the care paradigm that we're impacting on. If anyone wants to get in touch, so Tom and his team, you can see there that the time scales that we're trying to look at for prototyping with those 4 partners, health infrastructure, health pathology, and health share, plus eHealth New South Wales, is very much looking at those types of scenarios in those types of timescales. 1 to 4 weeks, not 1 to 4 years. I suspect many of you in the audience will have a good handle on these types of topics. But again, just to reiterate, especially from eHealth New South Wales, often I think perceived as the tech organisation. But as I've just said, tech is wholly different from where it was, say 10 or 20 years ago when I started. See that it's the whole of the lifetime. So care pathways, including and beyond state. So care coming in from primary and Commonwealth, care coming across from private and back again, care moving across districts and specialty networks, care moving across borders and even countries. These are all of some of the challenges that we've got to ensure that our digital footprint gives the most assured and safe delivered care. Co-design and the multidisciplinary approach, very much the archetype of how we approach design and engagement. Fast is obviously one of those operative words. I'm looking for all of the work we do to really be safely truncated down to the most agile methodology of deployment. Touched on the prototyping centre for simulations, for test environments, but obviously the opportunity with the research fraternity is to go even wider than maybe the digital footprint that we're normally looking at in our care environment. There's so much more, and again, I think Joanna's presentation just before for this really exemplifies the depth that we need to go to for some of the evidence base for many of the products and platforms we're delivering on. I've touched on analytics. It's both one of my lodestones, guiding stars, but it's also one of our vulnerabilities. Everything we've talked about here depends on an incredibly strong accessibility and usability of the analytics that we use at a state level. Like we've just seen again from Joanna, understanding the impact of everything we do. How am I doing for time? So, as I said, I'm blessed by Zoran, my boss, as of the 1st of July, taken on the enterprise research. So all of the research capability within eHealth will now sit with me, yet it's the whole of eHealth. So eHealth, as I said, is an enormous organization, yet the research arm, and hence the opportunity to really link up with the audience and the wider audience online as well, is to really unleash the research capability, not only from the organisation eHealth New South Wales, but for all of the districts and networks, for the other pillars, and especially for the research community, not only in New South Wales particularly, but also the other states across Australia. I have to be a bit careful with the first topic, bullet point of single digital patient record, as it's going through a very delicate phase of engagement. So if we come back to this question, I might be able to give you more answers in a month's time, but I may be restricted if anyone wants to know a lot more detail about what that is. I'll give you the broad brush. The next generation of the electronic medical record is almost upon us, at a state level to unify all of the domains across the state of New South Wales. You can see also quality learning research as one of the key developments within the organisation for eHealth New South Wales, and very much in incorporation in joint partnership with the research fraternity. I would really like to understand, how do we do more? How do we cover greater amounts of focus? The vast estate of the digital care domain now is so large that it would require significant coordination, co-design, co-facilitation, and co-investment to cover the depth and breadth. Yet New South Wales sits at the very heart, in my perception, very much at a juncture of becoming clearly one of the global peer leaders of digital research in care and safety. 3 examples, and then that's me done, George, if that's okay. I think the Secretary actually referenced this one. So this is one of those that is actually born out of clinical challenge. Systems that were never designed to talk to each other. ICU platforms were designed to work in ICU. In the good old days, my days, I was, in my previous career, as you can tell from my Yorkshire accent, I was hounded for 5 years to buy this ICU service product and platform. Yet the whole design was it to stand alone as a platform. And therein lies all of our challenges going forward in the 2020s and especially 2030s. It is almost beyond belief that we will have any system that does not naturally and safely share information, care information, clinical information without an impediment of legacy interoperability or lack of. So this is one of those challenges, and again, many thanks to Mel Bissari for some of the work around trying to understand how information is shared from ICU to ward, medications reconciliation, and how it's done safely. But the more we look at this, it was more than just meds rec. It was around nursing handover to handover, care handover. As we know from our medical legal colleagues, transitions of care, whether digital, in this case ETOC, or other, are some of our most high-risk events in any care pathway. So you can imagine the overlay that we're looking at to ensure there is no new events that happen at these pinch points, these transitions of care. Briefly, because we don't have enough time, I'm sorry for this, but so just to call out another opportunity that we've looked, because again, I think, Joanna, you called it out. Not only is this ensuring that we don't have unwarranted or unexpected safety events from the new digital offering, but also that the new digital state of care gives us opportunities to do new care safety. So in this case, it's some great work by Professor Hilmer and her team, and again, thanks Mel, around drug burden index. We have already had some of the evidence from the papers shared by Joanna and her team. Polypharmacy, older people's care, aged care. This is nothing new, that many of our older population take significant numbers of pharmaceuticals. They also have a problem of some of the most challenging medications. Some of the sedatives combined with other interactive and contraindicated drugs can sometimes come together. So this is a digital way of highlighting to the clinical team, often trying to deliver care at pace, that there may be a risk associated with the combination of drugs. So Sarah would be more than happy to have further conversations if anyone wants to know more. Just to pick up, and I knew that Joanna was going to be doing quite a deep dive on the e-meds, especially from the children's perspective, but I just wanted to reflect on this last care slide. This is the pace that e-meds was rolled out. I was reflecting on time is probably one of our most precious commodities, but you can see as a state we went relatively slow, gained confidence, and in essence we deployed to 200 facilities across the whole geography of New South Wales in really 13 months. It's almost unheard of around the world to do it in that pace for that number of discrete facilities for that type of change event. So high five and praise for those who were part of that. Yet I think it may be, and I try and remember who asked the question around, why do we have such an interesting and challenging profile potentially in those first few days? Because you can see the amount of change that was happening across the state on the vast scale that is shown here. And again, for those members who would like to know more, for the next generation of digital offerings, we're going to look at doing this again. I will wrap up on that point. Look, I don't want to just dwell on the interoperability. There's so much more. And it's, again, a great opportunity, I think, for many of the members here, George, I'm happy for you to reach out. If people want to know more or be involved, especially, I think, as I said, New South Wales is in an invidious position to really step change in digital care research, not only in the quality, but also in the volume.
Okay.